Welcome everyone to the second session of our CHW webinar series. My name is Siapa Surathamrong from Community Partners International. And I would like to welcome you all to this exciting session on such a timely and important discussion about research with and by community health workers. Um, from our first webinar, actually, we have a very interactive session with a lot of engagement from the audience, and we look forward to have similar session from you all as well in the today. So we would like to welcome you to add your opinions or questions in the Q&A box as well. So this series is all about creating space for a dialogue, for connection, and for learning from not only just experts, but for people in the same community and same space. So I hope you enjoy the session. And without further ado, thank you again for joining us. And I would like to pass the floor to our moderators. Ninia Cleo, the floor is yours.
Thank you, Sia. Morning, afternoon, evening, depending on where in the world you are. Thanks, Sia. It's great to see you all. Thank you so much for joining us for this important session. Nothing about us without us, centering community health workers in health research. My name is Linnea Stansett-Katzen. I'm a public health researcher, and currently, together with my colleague Cleo, who will introduce herself shortly, we serve as interim research directors at the Community Health Impact Coalition, CHEEC. I'm also a researcher at Stellenbosch University in South Africa. And Cleo and myself will be moderating today's session together. For those who may not be familiar, CHEEC is a coalition of thousands of community health workers and global health organizations across more than 60 countries and 5 WHO regions. The mission is to make professional community health workers, pro-CHWs, the global norm. And for me, I've been working in the CHW field for over a decade, both in implementation and research, and I'm very excited to be moderating today on a topic that is so critical. A special thank you to CPI for the opportunity with us to co-develop and co-facilitate the session. As many of us know, while CHWs are often the subjects of research, they are too rarely engaged as genuine collaborators or co-leads throughout the whole research process. Today, we're privileged to hear from a great panel of speakers who are shifting that paradigm. We've got Mary Juma, who's a CHW and a CHW research representative at Advocates for Community Health Volunteers in Kenya. We have Dr. Noel Wiggins and Victoria Adwumi from the Community Health Worker Center for Research and Evaluation, the CHW-CRE. We have Dr. Karen Finnegan from Pivot Madagascar and Jane Wame from Luala Community Alliance. Together, they'll share experience and practical models of community health worker-led and co-designed research, explore power dynamics in global health knowledge production, and highlight strategies to advance equity and research governance. We're really looking forward to an engaged and collaborative sessions. So please feel free to drop questions and comments in the Q&A box. And we'll leave quite a bit of time at the end for discussion. With that, I'll hand over to my colleague and co-moderator, Cleo.
Yes, hello everyone. I would first like to extend a heartfelt thank you for joining this session. We can see over 100 participants already have joined. It's a topic really of such deep importance in the field of global health, and we're excited to dive into this session. As probably most of us in the field have experienced, community health workers are often excluded as authors and key decision makers in research, often confined to roles such as data collection and participant recruitment, but limited involvement in really strategic decision making around study design, analysis, and dissemination. This is an issue of equity, and it's also an issue in the sense that it weakens evidence. If the people closest to the work aren't helping to shape the questions, interpreting this data, and sharing the findings, we risk studies becoming less relevant, less trusted, and less likely to be used. So we see a fragmented landscape in global health research, where norms and guidance are not clear. It also suggests that there is a clear need to build capacity and research skills for community health workers and just provide the simple opportunities to be involved. And so these are the big topics that today's webinar is going to focus on, and I'm very excited to get started. To kick us off and to ground us in this conversation, I'm honored to introduce Mary Juma, who is a community health worker from Metisi Dispensary in Bungoma, Kenya. She's also the community health worker research representative to SHIC. She is a county community health worker lead and treasurer, an advocate for community health worker rights, and a co-author on work presented at the UN General Assembly. And she'll kick us off with what meaningful community health worker involvement looks like in practice.
Yeah, hello everyone. My name is Mary Juma, a community health worker, also referred to as community health promoter in Kenya. I'm attached to Matisi Dispensary in Bungoma County, where I serve my community by preaching access to essential services. Yeah, my journey in research was inspired by my active participation in CHW advocate groups, which nurtured my passion for evidence-based advocacy. Through this involvement, I have the privilege of working closely with Dr. James at Community Health Impact Coalition, contributing research initiatives, co-authoring work, advances, recognition, and support of CHW. Thank you. First slide, my journey. Initially, CHWs never participated in research, and my experience was being called by to identify patients or households to fill in survey forms. I was never involved in to decide what questions should be asked or how research should be used. I'm happy that this has begun to change through advocacy. Quote, nothing about us without us. And we are now recognized as researchers. Data collection is very key. Incomplete data or wrong data will design wrong interventions. CHWs are the best position to identify each household, and we reach unreachable from remote areas. Next slide, please. We've got barriers to CHWs as a researcher. And the first barrier is language. Many research materials are in technical language or in English, making them hard to understand or use. And we need translations and training so that nothing is lost. The second barrier is limited involvement. Too often, CHWs are brought in after a big decision are made. And we need to be part, setting the research questions from the start. The third barrier is lack of training and exchange. We need professional training in research methods and opportunities to learn from CHWs in other countries. Imagine Kenya, Uganda, Zambia, Malawi, and extra exchange skills and ideas regularly. Our research would only get stronger. Another barrier is lack of resources. We need the right tools, capacity building, and funding to do research well. And the last one is recognition and fair pay. CHWs should be recognized on paper as professionals in research and compensated fairly. This fuels confidence, commitment, and career growth. Second slide, please. These are community-led, co-produced research that I've done. One is community malaria mapping. Another one is HIV stigma surveys, maternal health improvement projects, water sanitation disease awareness. Next slide, please. Inspiring funders and institutions to shift towards inclusivity and equality in research. We need equality in decision making. We need representation in advisory board. Valuing indigenous knowledge is also key. Transparency in funding allocations. We need also joint evaluation of outcomes. Sharing real-world evidence is also key. Encouraging co-authorship with CHWs practiced. Presenting measurable local impact. Build founder trust in CHW capacity. Promoting inclusive curricula. Offering field-based learning opportunities. And finally, building mutual respectful partnership. Next slide, please. These are best practices. We need continuous capacity building, embedding sustainability by maintaining partnership, strengthening local research networks, and encouraging mentorship of new CHWs. Sharing knowledge openly, ensuring community retains ownership, cross-learning between regions, participatory monitoring, community validation of findings, adjusting methods based on feedback, clear, open communication, mutual respect for all contributions, ethical guideline tailored to context. Thank you. That's the end of slide. Thank you very much.
Thank you very much, Mary, for sharing your expertise and your experiences. Again, please add your questions in the Q&A box, and Mary can respond to them when she can. And I have the pleasure of introducing our next speakers, Dr. Noelle Wiggins and Victoria Dewumi from the Community Health Workers Centre for Research and Evaluation, the CHW CRE. Victoria Dewumi is a public health practitioner and community health worker with experience in municipal, higher education, and faith-based organizational settings. Her work includes facilitating community empowerment and establishing health equity interventions for marginalized populations through coalition building, service, case management, policy, and advocacy. Victoria is also one of the co-executive directors and principal investigators of the CHW CRE. Dr. Noelle Wiggins is co-principal investigator and co-executive director for the Community Health Worker CRE. Dr. Wiggins has over 35 years of experience leading teams that use popular and people's education, community health worker models, and participatory research and evaluation to advance health and educational equity. She co-founded the Community Capacitation Center at the Multnomah County Health Department in Portland, Oregon, and served as the director from 1998 to 2017. We are very grateful to have you both on the panel today. Thank you so much. And with that, I will hand over to you. We're doing a joint presentation.
Thank you so much. We'll go to that first slide whenever you're ready. And we are so grateful to our partners at CPI and CHIC for inviting us to be part of this webinar. We're based in the US, and we are so grateful for everything that we have learned and continue to learn from CHWs and allies across the globe, and truly are honored to get to be part of this important work. So we have some important objectives that we would like to accomplish during our time together. We are excited for this work to hopefully support your own learning and development in this important topic. By the end of the session, we're hoping that you'll know what CHW CRE is, what we do, and how to contact us. We want to make sure that you're also familiar with our new tool, which is creating a new table, which summarizes best practices in CHW research and evaluation. And we also want you to understand, and again, so grateful to Mary and the incredible insights she just shared. The importance of centering CHWs in research and evaluation really requires a shift in how we think and work in organizations. And so that's something that we hope is communicated during our time together. We also are popular or people's education practitioners. And for us, that means that we are all teachers and we are all learners. During our time, we're going to encourage but never force your active involvement. We are going to do our best to create knowledge together. And as importantly, if not more, we are going to have fun on our learning journey. So within the limits of time and technology, we are going to use a little bit of popular education today, and I will pass things over to Noelle to get us started.
Thank you so much, Victoria, and thanks to all of you who are on the panel and who are joining us today. We're so honored to be here. And if I might ask for the colleague who is kindly sharing the slides, if you'd like to move now to that fourth, I guess it's number 16. That's the right one. Thank you so much. We'd like to start by sharing a little information about our organization, the Community Health Workers Center for Research and Evaluation, or CHWCRE. And I'd like to start by asking you a question. This is part of our popular education methodology. I'd like to ask you to think for a minute about this question. Why do you think it might be necessary to have an organization that advocates and builds capacity for community health worker leadership in research and evaluation? I bet you have lots of thoughts about that question, and I wish that we could engage with you to hear them, but I know you're thinking out there. So I'm going to share a little bit about our experience and why we think that this is important. So in our experience in the United States, there is growing awareness that community health worker involvement can make research and evaluation more valid, more reliable, and more usable. And this is especially, but not only true, when the research and evaluation is about community health workers and community health worker programs. However, despite all that increased awareness, we feel like a shift in how we conduct research and evaluation is not going to happen on its own. So you can go to the next slide now. Perfect. So based on our experience since we started in 2015, it's been necessary to establish an organization to do three primary things. So here are those three things, and then I'll give you an example of each one of them. First, as Mary has already shared, it's important to build capacity in both community health workers and researcher evaluators to conduct research and evaluation together. So to build capacity, we offer interactive workshops using popular education for both community health workers and for researcher evaluators. And we also support experienced community health workers, like my colleague Victoria, to get advanced degrees in research-related fields. Victoria is currently in a doctoral program. And right now, Victoria, or one of our other colleagues, is going to put into the chat a flyer that lists the courses that we offer. And you can go to the next slide. We've also found that it's really important to model what community health worker leadership of research and evaluation looks like. It's important to show people what it looks like in practice when community health workers lead research and evaluation. An example of this is Community Health Workers for COVID Response and Resilient Communities, which is a project that was funded by the CDC, the Centers for Disease Control and Prevention, from 2021 until March of this year. In that project,
community health workers from the CDC and CHW-CRE were leaders in the evaluation team. And finally, next slide, we've found it's important to develop and use common evaluation indicators that are chosen by community health workers. Starting in 2015, our organization developed a set of 12 process and outcome indicators for community health worker practice. And these indicators were identified and developed based on asking community health workers two questions. First, we ask them, what outcomes are you best placed to achieve? And second, we asked, what workplace conditions do you need to achieve those outcomes? And we developed the indicators based on the answers that we heard. So now I'm going to pass the baton back to Victoria to talk about a new tool that we've just created.
Thank you so much, Noelle. And as mentioned, shifting the paradigm in research and evaluation requires new thinking, new skills, and also new tools. So we have recently produced a tool to help shift the paradigm, and we'd like to introduce it to you now. Our tool is based on our own experience, as well as studies and scoping reviews about CHW engagement in evaluation and research. And we often talk about people needing a seat at the table. Maybe you've heard that language, people needing a seat at the table in order to have their voices heard. And this is true, but we also recognize that sometimes to be truly and fully inclusive, it's sometimes we need to create an entirely new table. So as you'll see in the guide, as well as in our training courses, we use this metaphor called creating a new table. If we could go to the next slide, please. So this is a process map based on our tool, and it has two parts. It has a one-page graphic listing the best practices in short phrases. And then there also is a second document that presents each of the 4 stages and practices that need to happen at each stage, and also provides references where you're able to learn more. Next slide, please. So as mentioned, the tool has 4 stages or sections. The first is creating the table. This provides foundational practices to guide whoever is coming to the table, how they lead, and help them identify the problems that we will try to solve. Next is setting the table, which is containing core behaviors that everyone around the table needs to adopt and practice faithfully to ensure equitable participation. Then there's preparing the feast, which is a set of concrete strategies and frameworks that can help us share power and enact our principles. And finally, sharing the bounty. These are guidelines for how we share and use our findings. So this tool, along with many other tools, publications, the courses that Noelle mentioned, and more information about our work and how to contact us can be found at our website, www.chwcre.org. We can go to the next slide, and I'll hand things to Noelle to close us out.
And I will just say that if you're interested in participating in our work, we encourage you to contact us by filling out the interest form on our website that you can find at that address. Thanks so much.
Thank you both, and how amazing to be provided with a toolkit and tools that we can take forward in our research. And thank you for setting the scene of how it's an intentional process to have true inclusivity in our research. I am very pleased to introduce our next speaker, who is Dr. Karen Finnegan, a public health researcher with more than 20 years of experience conducting research in community health systems in countries around the world. Karen is a research associate at Harvard Medical School and the managing director of Pivot Science, leading research activities for Pivot, an NGO which works to strengthen the public health system in rural Madagascar. Karen has a PhD from Johns Hopkins University, Bloomberg School of Public Health, and an MPH from Emory University.
Thank you, Cleo. We can go to the next slide. And actually the next one. I want to start by doing a little bit of framing. I do research primarily with Pivot, which is an NGO that works to strengthen the public health system in Madagascar. Pivot works currently in one region of Madagascar, Vatovavy region. The work started in just one district in this region in 2014, with an emphasis on strengthening all levels of the public health system, community, primary care, and secondary hospital level care. The support of the Ministry of Public Health's Community Health Program launched in 2016, and it's been a learning journey for Pivot ever since. In 2024, Pivot expanded from one district to all 3 districts in Vatovavy region, and this included expansion of the support for the Community Health Program. In the last year, we've onboarded about 1,500 new community health workers, and this includes training as well as supervision, support in terms of financial support, medication, and some technology. We have seen this opportunity for expansion as an opportunity to rethink how we engage with community health workers as researchers in Madagascar. If we go to the next slide, I want to talk just briefly about why community health workers are so essential. Mary said community health workers meet people and are able to reach people in the most remote communities. And this has proven true in Madagascar. Looking at Ifanadine district, where Pivot started, we see that when we look at average consultations per capita per year for children under 5, the dark black line shows consultations at a health center, and the gray line shows consultations with community health workers. The x-axis is distance from the health center. So it clearly demonstrates that more than 5 kilometers from a health center, community health workers are the ones providing essential primary care for sick children under 5. If we go to the next slide, to highlight the role of community health workers in Madagascar, like so many countries around the world, community health workers provide sick child care using the Integrated Management of Childhood Illness guidelines. They do referral to health centers for antenatal care services. They provide family planning, and they do sensitization and community awareness raising around essential health topics. They are playing a key role in their communities, and building upon this work, we've engaged them in 3 initiatives along the research life cycle. If we go to the next slide, I want to talk a little bit about these initiatives and a key takeaway or lesson learned from each of them. So one of the roles that community health workers play in Madagascar is they provide sentinel surveillance for events that may indicate the start of an epidemic or a zoonotic spillover event. Historically, this reporting has been paper-based, where community health workers complete a paper form and submit it to the health center. With Pivot support, we've developed a module in ComCare so that community health workers are able to do this reporting electronically, making the process easier and hopefully faster. We've engaged community health workers in a pilot of this module where we trained a small number and they've been using the module for about 6 months and are able to provide feedback on how it's going. This is an iterative process where community health workers are involved in the co-design of an intervention, where we're taking an existing system, hopefully making it more usable, and incorporating community health worker feedback in how data are being collected. On the next slide, we talk a little bit about engaging community health workers in research from the start. I noted that we've recently done recruitment for a huge number of new community health workers. And as part of these expansion activities, we are building out a research agenda that looks at answering questions around community health implementation, impact, and utilization across Vatovavy region. We've been really intentional in pairing this expansion with the development of a community health research working group that brings together community health workers, partners, and regional leadership of community health for a working group that meets a couple times a year. This is an opportunity to co-construct the research agenda for the region and think about what are questions of importance for everybody who comes to the table to have this discussion. One of the things and one of the lessons learned for us in thinking about this was that it's been really important to think about hierarchy and the roles that people play and the perceptions that they have of each other as we come together in this research working group. So we've done a lot of work in our initial session around thinking about how we're all human and not just our professional roles, but that we really all are experiencing the health system and want the same things when we think about healthcare and community healthcare, regardless of the role that you want or the role that you play. And then on the next slide, the woman in the blue shirt, Feti, is a community health worker who's worked in Ifanadine district for more than 7 years. At the most recent American Society of Tropical Medicine and Hygiene conference, we convened a panel talking about Madagascar and climate change and health. Feti joined us and spoke about her experience as a community health worker during and following Cyclone Batsirai, which hit Madagascar a couple of years ago. Community health workers are called to help their communities respond to these types of events. And she has really interesting and unique insight into the roles that community health workers play with climate change and health. She was able to talk about her experience and reflect on the role of community health workers. And she also was able to participate in the conference at large. I will say she had really an excellent insight into many of the presentations that people were giving on community health work research and their findings, and thinking about a real practical lens and what those results would mean for her in day-to-day implementation. One of the lessons from this takeaway was around the importance of accompaniment and support for community health workers as they engage in spaces that have traditionally been much more academic and scientific. Just like all of us need support when we first enter into these conferences, it's this very similar process in helping people prepare and thinking about what to expect at these academic conferences. So those are just 3 of the ways that Pivot has been engaging with community health workers at different points along the project and research spectrum. In the final slide, I just want to acknowledge that I'm one voice, but there's a very large team of people who are working on all of these projects. So there are some community health workers in the group photo, and then members of our science and implementation teams who have contributed to this work. And I was limited by space, but there are many, many more people behind this work. So thank you.
Thank you so much, Karen, for that really insightful and great presentation. It's really fascinating to hear some of the sort of practical approaches on how to actually include CHWs meaningfully from early on in the research process. So thank you for sharing that. I'm now pleased to introduce our final speaker for the day. Jane Wame currently serves as a senior research analyst at Luala Community Alliance, which is a community-led health organization based in Western Kenya, where she leads the design and analysis of mixed methods research for programmatic learning and policy advocacy. Jane's work integrates rigorous data with lived experiences and employs these learning to inform programming for improved primary care access, better maternal and child health outcomes, and strengthen the capacity for community health workers. Thank you for joining us, Jane. I'll pass over to you.
Thank you, Linnea and Cleo. Let's go to the 3rd slide. Hi, everyone. I want to start by talking about what Luala Community Alliance does and who we are, so that you understand how we engage community health workers and what kind of research we do. Next slide, please. So Luala Community Alliance is a Kenyan-led organization that was founded by a community in Western Kenya that dared to fight back against health inequity. The community members contributed resources, land, labor to start a health center in the Luala village first hospital. The hospital now serves many people, and we have since grown in leaps and bounds and have programming that we conduct as well, not only in Luala village, but across several counties in Kenya. Next slide, please. So how we do programming is through our tried and tested community-led health model. And the model encompasses or entails Luala co-implementing with the county governments, where professional community health workers, and professional, I mean that they're trained, that they're equipped, that they are remunerated, that they are supervised. They work in the community and also work as well, linking community members to health facilities. And we also work to improve the quality of care at these health facilities, public health facilities. We also partner with community health committees, which help to strengthen community health work and community health systems. And with all this work with community health workers, health facilities, and community governance structures, the overarching aim is data and policy and advocacy. And I'm going to speak more on the data in terms of the research work that we do here at Luala. Next slide, please. So research at Luala, we do a lot of scientific studies here at Luala. We have an in-house team that designs, together with our partners, we analyze the data, we report and publish and disseminate the data. So far, we have some of our interesting studies that are relevant to this webinar is the community health worker study, where we look at community health worker knowledge and performance. And we also have a very large household study, which is a triannual study. So far, we have published 23 papers in peer-reviewed journals. And currently, we are writing a journal supplement for the household survey study, where we will publish 15 papers in one journal supplement. Like many organizations, we conduct research. You design the study, you collect data, then you disseminate. But in recent years, a few things have influenced how we do research at Luala. And one of them is the Community Health Impact Coalition paper that has been spoken about today. And I've linked it there on the slide, where she did the study and found, very few community health workers are acknowledged or included as co-authors in community health worker studies. And additionally, we started working with the Wellcome Trust on a project called the Center for Exchanges project, which I will speak about shortly. Next slide, please. So those are the two things that have influenced our shift to more community engaged research. So although we include community health assistants, we include lead community health workers in data collection and the research process, we need more to be done. And some of the things that we are doing is one, on the Wellcome Trust project, we are working with the Wellcome Trust and 8 other organizations based in India, Kenya, and South Africa to find and share better ways where communities are most affected by health challenges can inform health research. Next slide, please. So one of the major shifts based off the Community Health Impact Coalition's paper, which we are a member of, CHIC, is in the community health worker study that I mentioned earlier. It's a multi-year study where we do a sort of pre and post test evaluation of community health workers' knowledge and performance before training and post training. We have had it for a number of years, and this year is the first year that we are having 2 community health workers as co-authors on the most current research manuscript. Additionally, you will see on our website, which is on the Luala website under the impact page, we have a section on research where we post all our published papers. So traditionally, we would disseminate these research findings through publications and through organizing dissemination events. But now we started synthesizing the results into sort of, for lack of a better word, bit-sized infographics where we share back the results with the community health workers and in their language. So for example, in one of the counties that we work in Kenya, we share the infographics in the local Luo language. So some of the studies we've published there, we also have infographics for community health workers in their local language. We are also creating an environment where community health workers can give feedback and contribute to the research process, for example, by attending their monthly meetings and having various interactions and touch points. Next slide, please. So the next slide is an example of an infographic from one of our studies from the household survey, where we found that women who experience or interpersonal violence was found to be more prevalent among women who have been or are currently widowed, divorced, or separated, and also women who are exposed to interpersonal violence in childhood, and women experiencing severe depression. So we translated that and made it into an understandable language for community health workers. Next slide, please. Some of the other things that we are doing is, for example, learning and sharing under the Wellcome Trust Center for Exchanges project, where we are really learning and diving into knowledge sharing, health research knowledge sharing. And also, with the help of that project, we are involving community health workers in the design, writing, data analysis, and validation of the household survey. Finally, I wanted to give a few practical tips on how to think about, next slide, please. I wanted to give a few practical tips on how to think about engaging community health workers in research. And one of them is you need to budget for CHW engagement in research. So for example, they may need airtime, they may need transport reimbursements, for example, to come to dissemination events. You may need to also budget for translation costs for information and education and communication materials, and also staff time. You need to create an environment that will allow community health workers to give feedback and participate in research, and also have internal capacity building on community engaged research, as well as assessing the community health workers' need. And I had someone mention that, finding out where do they want to be involved in the research process. Finally, on my last slide is a call to action to have more funders and stakeholders. Next slide, please. To have more funders and stakeholders fund projects similar to, for example, the Wellcome Trust Center for Exchanges project, as well as everyone to have an intentional involvement of community health workers. For example, I hope we have community health workers here in this webinar, and that we will also have community health workers attending the symposium in November. Thank you.
Thank you so much, Jane. It's a really great call to action. Thank you for your presentation. And thank you to all our panelists for these incredible presentations of experiences and reflections on this topic. We'll move on to a bit of a Q&A session. We're going to pick up some questions from the audience for the next few minutes. So I think I'd like to start, and I think we'll direct this to Noelle and Victoria, if that's okay, is how to avoid biased effect when we collaborate with CHWs and impact evaluations of programs where CHWs are the direct beneficiaries of the program intervention. So if you would like to address that. Thank you.
I'm happy to start, and I'll ask Victoria to please build on what I have said. So I was actually just answering that question in the chat. Most of our outcome indicators do not ask directly about the influence of the community health worker on the outcome, and therefore bias isn't introduced when the community health worker collects that data. We do have one retrospective indicator about increases in empowerment among community members that does ask about the influence of the community health worker. And so in that case, we've collected that information in a variety of ways, by phone, by a paper survey, but the data isn't collected by the community health worker with whom the participant worked, but rather by someone else on the team. So that's a first thought about that. Victoria?
I think that's a fabulous answer, Noelle. And I'm actually looking at the second part of the question in the chat of the strategy to ensure sustainability of CHW involvement given high turnover rates. And this is something that feels a really, really important question to be thinking about because, and I love how Noelle describes the CHW profession as both ancient and emerging. And so CHW roles, while there absolutely are sustainability concerns, ideally these are folks that are embedded in communities, as we already have talked about, and as I know folks listening already know. And even if the role, the CHW role that they're in, even if there's attrition and challenges, ideally they're being compensated, as we heard from Mary, and they're conducting and participating in research that feels vitally important to themselves and their communities. And so even if there might be attrition in the title, ideally there are other mechanisms to keep the individual who still should be able to leverage extraordinary relationships with the communities that they're working with, invested and connected. I'll say again, fair compensation for those individuals, opportunities to be participating in research that feels applicable and important in changing how things actually operate in their lives and the lives of their communities. All of those feel part of the solution and really supporting full, authentic, and longstanding CHW engagement in research. Noelle, what did I miss there?
Nothing.
Thank you. Thank you both for sharing that. I'm not sure if anyone else on the panel would like to add to that. Maybe particularly the second part of the question around sustainability. Perhaps Jane or Karen working more on the ground, or Mary. Any thoughts on that?
I will say that I do think engagement in research can help improve job satisfaction and engagement, and is often thought of as a retention strategy. And sort of divorced from thinking about community health worker retention. As a researcher, I think more researchers are better. So even if a community health worker were to leave their position, I still think more people thinking about research, regardless of their profession or what hat they are wearing, is a win for our communities. So it is, of course, an important concern thinking about sustainability and the investment that it takes. But in general, I think the investment is a good one, regardless of how long people may retain their specific roles.
I can pull from a question that Joan Muti just placed about how community health workers might have to juggle between different actors in a region. So NGOs, government, private sector, and how that might affect the results. I think, Karen, if I pointed to you, as I think you have some experience here.
We are and I say this reflecting that there's a large team at Pivot and people who think really deeply about these concerns. We've been thinking a lot with this expansion activity around partner harmonization, not just about research, but about what a community health program should look like. And I think payment of community health workers is one where this comes up a lot, where different partners might pay different amounts of money or through different mechanisms. And I'll say that the Madagascar government has been quite a strong voice in thinking about what a uniform policy would be. That's just one example of the ways partners can pull community health workers in different directions. And I think it's our responsibility to be a good partner and really think about how we can advocate for community health workers and not create instances where things might be in conflict, or we're creating sort of negative feedback loops.
Thank you, Karen. Okay, we have quite a few questions rolling in, and I'm going to pull on one question that I myself am very interested to hear on: how do we balance community health workers' involvement in research and community health workers' services delivery? How can we avoid this stacking up of tasks? Do any of you have any practical advice here?
Thank you. Maybe my opinion is not to view research as like a standalone feature that has to be addressed on its own. I feel research should and is good to be embedded on day-to-day work and programming. So there are times, and then God, you don't collect, for example, data every day. There are times maybe you may be running a data collection and or disseminating, and you're inviting community health workers. If it's part of embedded into systems and the work they do for improvement and learning, that is good. But I want to give others a chance as well to respond.
I'll just say briefly, and then I definitely also want to make room for other voices we haven't heard from yet. I love, again, something that I so appreciate Noelle reflects on, this idea that participating in research and evaluation actually strengthens CHW's abilities to feel confident and effective in other areas of their role. So this idea that, again, I think Jane said it beautifully, that it's not sort of this one disparate activity and then their real job in doing sort of these other things, that there's this really beautiful interplay that builds capacity for the CHW, builds confidence, builds awareness of needs, and contextualizes those needs for CHWs and the work that they're doing. And all of those actually strengthens their ability to deliver services. So all of those things sort of working hand in hand feel really key as we think about ways to expand opportunities for CHWs to be doing this work. Noelle, anything you wanted to add?
Well, just building on what you and Jane have already said, I think here in the US, participating in research and evaluation has been recognized as one of the 10 core roles of community health workers. And so we really encourage program developers, when they're developing position descriptions, to include participation in research and evaluation as part of the basic scope of practice of community health workers. And I think that conceptualizing the role that way from the start makes it much easier to build that work into the job of the community health worker.
Thanks, everyone, for these great responses. We are almost out of time, but I wanted to hand over to Mary to see if you wanted to add to this last question in particular, considering your expertise.
Community health workers are just essential partners in research and not just participants. Our lived experiences, trusts within the community, and deep cultural understanding help bridge gap between the scientific inquiry. So by valuing CHW contributions, research becomes more relevant, ethical, impactful. So I think that one is just part of my contribution on behalf of that.
Thank you,
Thank you so
Mary.
much, Mary. That's a perfect way to wrap this up. I just want to thank all of our panelists for such an excellent conversation on need, the equity need, but also how this just improves our field of global health research, and providing us with some very practical tips and tools on how to do so, and also some ways to rewire what we think about true inclusivity. It's something that takes intention, and it's something that, as Victoria so well put it might require making a new table. And we will work with CPI to see how we can share all of these resources that were discussed today with everyone, including the studies that were brought up. But yes, thank you for everyone for joining. And I'm going to pass it to Sia for a quick message from CPI. But thank you everyone again.
And thank you the panelists for such a engaging conversation on such. I would like to promote the next webinar in the series, which will focus on sustainable health financing. For those of you who already subscribe to our mailing list, will get the news about the registration in due course. And we are now also accepting abstracts for the fourth Community Health Workers Symposium. So feel free to visit our website for more resources and all the recordings and materials from the conversation from this webinar will be uploaded on our website very soon. So thank you again for attending.